Well, hello everybody. Can you guys hear me?
Yes. Yep.
All right. Well, it being the last last Thursday of August, we have our monthly Northeast South Dakota AHEC and District 4 EMS training tonight. Thank you all for being on. I know it's kind of a busy time of year, but thanks a lot for joining in and getting the hours. Again, if you need hours, make sure you put it in the chat box and we'll get those to you. I know we've had kind of an issue with some of the ALS hours. We're working on those. I know you've heard me say that for a while, but we're working on getting all that stuff straightened out. So tonight we have Dr. Josephine Combs from Sanford and Sioux Falls going to talk to us about concussion care. So I will let Dr. Combs introduce herself and take it from there.
Thank you. Yeah, I'm Dr. Josephine Combs. I'm a clinical neuropsychologist. I'm the concussion specialist for Sanford. I run the concussion clinic. Yeah, I'm going to share my screen with you guys so we can dive right into the presentation. There we go. Yeah, so I don't have any conflict of interests or anything like that to disclose. That being said, this talk is gonna focus on concussions specifically. I know as first responders, EMS, you address all kinds of injuries, but today we're just gonna focus on that very, very specific subgroup. So first, we're gonna kind of try to define and conceptualize it a little bit. I'm gonna talk a little about the multidisciplinary approach to this kind of injury, just because there's a lot of things that have changed and developed in the last decade. And then hopefully through that, we can improve awareness and knowledge. So as already kind of hinted, this is kind of like a subcategory. So there are many, many different types of head injuries that you may encounter. So if we want to kind of break brain injury down a little bit, we have the congenital, so we're not going to focus on that today at all. And then we have the acquired, which is typically what first responders, any kind of people on the front line tend to deal with the most, non-traumatic versus traumatic. And then within the acquired traumatic brain injury, we have further subcategories, which are mild, moderate, and severe brain injuries. And so today, we're going to focus exclusively on that mild or minor brain injury, also referred to as concussion. So throughout the talk, MTBI and concussion is going to be used interchangeably. They're synonymous in most contexts. Usually MTBI refers to mild traumatic brain injury. Sometimes there's a little bit of confusion because unfortunately moderate TBI also starts with an M, but typically when there's reference of MTBI in any kind of literature, they're referring to mild traumatic brain injury. Most traumatic brain injuries occur each year, are of the mild category. And an MTBI or concussion is caused by a blow, a bump or a jolt to the head, or by a hit to the body that causes the head and the brain to move quickly back and forth. I'm going to say this several times throughout our time together, just because that is a very common misconception, because concussions do not require a direct blow to the head to have this kind of injury. Any kind of sudden movement can cause the brain to essentially shake, bounce, twist, whatever we want to call it, inside the skull. The word concussion is Latin. It translates to shake violently. So that's literally how it got its name. And that kind of movement, because that's not supposed to happen, leads to essentially chemical changes in the brain. And that kind of movement can stretch and sometimes even potentially damage cells. And these type of changes in the cell structure lead to symptoms that can affect how a person thinks, learns, feels, acts, and also sleeps. And we're going to dive into symptoms more in depth as well. Something that is very, very important to kind of think of is always to consider the cause, right? Anytime there's a big force, there's a big impact, we want to be thinking about what happened to the head. So any kind of car, motorcycle, or bike accidents are almost always a reason to pause and at least kind of examine or ask that type of questions. Any kind of falls from a greater than standing height. Anytime we fall several feet, whether it's ladders, chairs, whatever people climb on, it doesn't really matter, because if we think about the pure physics of things, the greater the height, the greater the force, and so on. Anytime there's a physical altercation or any kind of violent shaking, that can also lead to that. And when we talk about violent shaking, people often kind of associate it with domestic violence, which certainly is common, but even very dramatic roller coasters or very, very brutal roller coasters have been known to generate enough G-force to leave people injured. So shaking, not just through violence, but sometimes entertainment, fun. So kind of keep that in mind, like what kind of force we're actually talking about. When there's an electrical shock or a lightning strike, that can also cause jolting and a lot of movement, enough to generate difficulties to generate injury. Obviously, any kind of sport activities, especially contact sports. That being said, concussions often get associated with sports, but there's certainly not a limit to it. Just because honestly, anybody that hits the head or has another type of significant force to the body can end up with this injury. It's just that it most often gets talked about in the sports context. For this talk, I'm not going to distinguish between sports concussion and non-sports concussion. We're just going to talk about the injury in general. There are a few differences in terms of management, but honestly, at the end of the day, a concussion is a concussion. And in clinic, I don't care how the injury was. I mean, I do care because I need to know from my patient, but I don't make a difference between sports related or non-sports related concussion. I see all of them in clinic. I find that within the medical community, for some reason, there's often a distinction where some providers will only see sports related concussions. I don't have a good answer as to why, besides I think that's what the context that it is traditionally thought of in and conceptualized. But like I said, it is not limited to sports by any means. It can happen in any scenario, anytime there's a human involved, it could potentially be a concussion. And I always like to joke that I've seen every sport in clinic, unless we're counting chess as a sport. I have not seen a chess player with a concussion, but any other sport, it doesn't matter how much or little contact is involved. I've seen swimmers, I've seen golf, I've seen tennis, dance, ballet, obviously football, hockey, race car, you name it, it happens. Another type of mechanism that can that leads to very, very frequent TBIs is any kind of exposures to blast. So whether we're thinking construction accidents or military, any kind of explosion, any kind of force can certainly lead to that as well. Injuries to the outside of the head, so anytime the skull is affected or gets grazed or we have lacerations, we always want to be aware of that too, because that kind of force can translate. And then general often rule of thumb is also that anytime there's a loss of consciousness, we want to make sure that there wasn't a blow to the head, just because typically people don't faint for no reason. Not saying it can't happen, syncope is not uncommon, but we at least want to explore what caused that. I already told you about the myth. Basically, it used to be long thought that it has to be a direct blow to the head. It absolutely does not. Anywhere to the body, if the force is big enough. Think car accidents, anytime there's whiplash motion, and so anytime the neck gets jolted too, that can certainly be a sufficient mechanism. So when the brain gets shaken, we already talked about it. Concussion comes from Latin to shake violently. When the brain gets shaken, basically significant changes in the cerebral glucose metabolism occur, and that impacts how things go from there temporarily. So essentially you can think about this as a metabolic cascade. Potassium rushes, we have the neurons essentially get stretched out, temporarily get leaky. And so these chemicals get out of place, leading to a temporary malfunction of the cells inside the brain. That being said, those cells get only temporarily stretched. They don't break, they don't rip apart. It's that metabolic change. And that is why concussions are considered to be functional injuries and not structural ones. Because as we reviewed earlier, structural changes bring us more into that moderate to severe traumatic brain injury territory realm. So these metabolic changes, that cascade is very much temporary, and those cells are coming back into their original shape, and then they're able to start working again. It's really important to know, as you can see from the picture, that this metabolic cascade, yes, it happens pretty quickly, but it doesn't settle until way later, which is also why a lot of concussion symptoms sometimes don't even show until 24 or 48 hours. There have been cases where people report symptoms up to a week later that they were unaware of. Typically, the first 48 hours is the most common time frame. If you have someone that will report something like a week after, typically they took it very, very easy during those first days and did basically nothing. And it wasn't until they attempted their normal day-to-day things that they then realized, oh, I'm having these symptoms. So a lot of times when there's that much of a delay, it's the symptoms have been there. It just wasn't expressed or triggered because they basically did nothing. They were a couch potato for however many days. It's also really important to know that Glasgow Coma Scale is not a good indicator for concussion, because you can have a completely normal score and still have a concussion. So it's helpful to kind of have that awareness, especially if we kind of think about, we talked about different types of injuries, or different mechanisms of injuries that lead to concussions, whether it's sport, MVA, work accidents, slip and fall, you name it. It's not uncommon, especially when it is in a traumatic setting, like, for example, a car accident, that adrenaline is running and people are very kind of hyped up and trying to, make sure everybody else that maybe was in the car is taken care of, or those kind of things. So adrenaline can also lead to that kind of delay in symptom presentation, because a lot of times at the scene, people will tell you, oh, like, no, I'm fine, nothing hurts. And then a day or two later, like, oh, wait a minute, that doesn't feel good. It's also really helpful to know that concussions do have risk factors, pre-existing risk factors. And a lot of risk factors we might not be able to glean right away, especially if it's if we're at the scene, first responder, if it's in the capacity of where we know the individual, might have a better shot, like, for example, an athletic trainer with an athlete that they're familiar with or something like that. But individuals that we are not familiar with, we might not know those things, but it's still helpful to know that there are pre-existing risk factors to caution us, to make sure we assess for the necessary things. There's no cookbook, cookie cutter approach to how to make a concussion better. It's not a one type fits all kind of thing, which is why we'll talk about the multidisciplinary clinic approach a little bit more. And setting wise, obviously, I don't need you to replicate that, but I think it's very helpful to be aware that that's even out there, that that's available. And two, also, I think it will help for a deeper appreciation or understanding of this kind of injury. Common signs and symptoms, or often also referred to as acute markers. You are all I'm sure you are all aware of these, but we're just going to go over it anyway. But loss of consciousness or being motionless. I cannot stress this enough. Loss of consciousness is not a diagnostic criteria for a concussion. There's still a lot of definitions out there that kind of endorse this, that are old, that are outdated. I'll talk about updated good information a little bit later, but it does not require LOC to have a concussion. Matter of fact, the vast majority of concussion actually occurs without any kind of LOC or even gross neurological signs or symptoms. So that is not true, and that has we've known that for a while, but just like anything in medicine, it takes a while to update things. Another common marker or symptoms is amnesia, either retrograde or anterograde. So can they remember before, after? I often have athletes that can tell me what they had for breakfast, but they have no idea how they got hurt in the game, or work comp. They remember going to work, they remember chatting with their coworker, but then that's it. Or on the flip side, we have lots of patients that remember waking in the ambulance or even the hospital or. So just kind of memory impact, because at the end of the day, when the brain is busy surviving and trying to keep everything else going, it's not so worried about storing memories appropriately. So those gaps are fairly common. Disorientation, confusion, again, not a requisite. It can happen. It can have various degrees of severity. Some people ask the same question 50 times, even though they've gotten the answer 49 times. Some people just aren't quite sure how they got where the accident happened or where they are now. It varies. Headache is a hallmark sign. It is very common, but it is not required. There are people that have concussions that do not have headache as one of their symptoms. There's a total of 21 different symptoms. We'll go into that a little bit more. None of them are required. So that's another reason why clinical evaluation is always important. It's kind of about the cluster of things, all the data combined together. Nausea, vomiting, very, very common. Queasy or feeling, lightheaded is often kind of what people also report with that. Same with dizziness, feeling off balance, feeling swayy, uncoordinated, like movement, staggering. Sometimes also when someone goes down after a hit, you kind of see almost like a fencing response. That's also a pretty good sign. Blurred or double vision. Some people have immediate vision changes after an impact or the injury. For some, there's a delayed onset. Remember, there is at least a 48-hour time window, if not even bigger, where symptoms kind of present as that metabolic cascade settles, as things kind of calm down. Slow reaction time, repetitive statements, either asking the same questions, I already mentioned that, or saying the same thing over and over again. And then obviously a lot of times concussion and neck pain, cervical kind of discomfort almost always goes hand in hand, because clearly attached and, so often involved. Symptoms and signs continued, red flags. So any of these, always our alarm bells should go off. Anytime there's like weakness, tingling, or any kind of burning sensations in the extremities, we want to make sure the spine is intact. We want to make sure nerves are okay. Severe or increasing headache is a little bit tricky, because again, headache is like a hallmark sign of concussion. So we expect people to have headache, but we're talking about excruciating pain. We're talking about like 8, 9, 10 on that pain scale, like really, really bad. And a lot of times it's also when it gets increasingly worse and just becomes unbearable. Inability to arouse the patient if they're not responding, if we can't get them to regain consciousness, we always want to get them to the ED. Anytime they have seizure activity or are convulsing after an impact. Slurred speech is also concerning. Increasingly restless, combative, or agitated. Again, we're not talking about the athlete that is mad that he got pulled or she got pulled from the game because they're having concussion symptoms. We're talking actual agitation. Repeated or uncontrollable vomiting. A lot of people will throw up after they have a concussion, some even several times, 3 to 5, depending on how much they have in their stomach. can all be within normal limits, but if it doesn't stop, if they can't, you know, kind of catch a break, we definitely want to get it checked out. The biggest giveaway is always, and that's I'm sure true for many things, but rapid deterioration. If they were talking to you a minute ago and all of a sudden they can't keep it together, can't keep their eyes open and are going back in and out of consciousness, they need to go. They need to be transported. We need to move. So these are just kind of, you know, common red flags. There are more. Some people will include uneven pupil size, which I see that a lot in clinic, and they didn't, and many of my patients did not require emergency transport. Some sources listed as it kind of depends. Again, all of these are more like accumulation of data points rather than just one make or break it thing. But again, no matter what you're faced with, keep in mind that a concussion is an evolving injury. They might look fine when it just happened and several hours feel awful, or a day later or two. Especially in that acute phase, 24 to 48 hours, changes can be pretty significant. So what kind of symptoms definitely require emergency attention? We already kind of talked about it. Seizure activity, always. Decreased level of consciousness, and inability to arouse, inability to get them back or keep them conscious, irregular respiration. We got to make sure they breathe. We always want to make sure that that's all okay. Obviously, check airways, all that stuff. So duration of loss of consciousness, again, kind of depends on sources. Some sources say 15 seconds. Some are willing to go as far as 30. Typically, anything less than 5 minutes, doable. Anything longer than that, we will get concerned. Any signs and symptoms associated with spine, skull, obviously fracturing, any kind of bleeding, and then, like we already talked about, significant mental status changes. So again, rapid deterioration. If they're chatty and telling you everything, and then all of a sudden they stop it or start slurring their speech, or that's always a sign that we need to move, we need to act. Also, we always want to pay close attention to our elderly patients, because with age, our brain actually decreases in size, like that volume loss. So there is more room within our skull for the brain to move, to get shaken, which then in turn can lead to potentially higher risk of a subdural or, you know, the injury. So especially, I know we talked earlier in terms of mechanism, in terms of, you know, greater than standing height for falls, but especially for elderly people, even a stumble could potentially cause a bleed. So general guidelines, again, depending on the literature you pull, some say 60 and up, some say 65 and up, but that almost, so that kind of, depending on which guideline you go with, always warrants neuroimaging to make sure that that didn't happen. We also always want to make sure whether the patient is on any kind of DOACs, just because any of those kind of medications put the individual at a higher risk for bleeding. So we want to make sure that those, even with the lower impact, get evaluated, because it does not require the same amount of force as for someone that does not take those medications and or is significantly younger. Common signs and symptoms, we've talked about it, you're well aware of them, but I do always like to point out, I've talked about that delay in onset, but we focused very much on the first 24 to 48 hours, right? So that's kind of where that left column is coming from. A lot of those are very typically they're early on, but there's even more that can kind of creep in as time goes by. So if we look on the right side, changes in sleep pattern, emotional changes, emotional sequelae of concussion, whether it's clinical depression or anxiety, or just significantly changes in mood that do not meet clinical diagnostic criteria. But being more irritable, not feeling quite like yourself, being off. Those are symptoms that are known to have a delayed onset, several weeks at times, sometimes month, depending on how the injury is progressing. So I've had cases where people talk about, he was doing so well in school, and now all of a sudden he doesn't really spend time with his friends anymore, or he doesn't like to chat anymore, or those kind of things. And if there's a known previous mechanism, previous injury, we always want to double check, because those kind of things can kind of creep in and fly a little bit under the radar. And so it's always helpful to be aware of that. And I cannot stress enough that especially kind of that emotional sequelae of concussion can be very, very significant. And for some people, and so in terms of like a timeline, so this is based on basically on symptoms. And this is just a suggestion. Obviously, every brain is unique. Every brain is a little bit different. Everybody has different risk factors they bring to the table. Every situation is a little bit different, but in general. So if they need immediate emergency attention, obviously when there's red flags, right? We just talked about that. That is crucial. Anytime we have red flags, we need to act within the first 24 to 48 hours. So like the day of the injury or even the next day. So it's not necessarily emergency transport. They might not need, an ambulance, right? They might be able to get themselves to acute care, their primary or the ED. But typical symptoms for that, tinnitus, we talked about amnesia, any kind of cranial nerve deficits, vomiting, even if it's not uncontrollably, if it doesn't stop, it's not a bad idea to get checked. And then any kind of subsequent deficits that weren't at the initial eval, like in this example, it says on field because for athletes, but even that you check them at the scene, they were fine. Now they're getting home, and all of a sudden, like not like motor deficit, sensory balance, right? Like again, adrenaline goes a long way. They can keep it together while they have to, and then they're home, they're safe, and they fall apart. In terms of like a delayed referral, so days after the injury, so the first week is typically a good kind of time frame to see if there's any kind of symptoms that worsen, that the trend is not positive, meaning the symptoms do not go down, or more and more symptoms start popping up as we try to do more things and go back to life. And especially when those symptoms interfere with daily activities. We talked about sleep dysregulation, but even like cognition, like I went back to work and I just cannot focus. I can't even read my email or whatever. And then typically, and I say typically, the average concussion can be anywhere from 2 weeks to 6 months. That is a huge, huge time span. And we'll get into a second about why that is. But all of that is technically considered normal. The average young, healthy individual bounces back within 3 weeks. So average kind of like 3-ish weeks. And in those 3 weeks, we want to work on a return to play, a return to work or academics, depending on age group, depending on the individual that got injured. But it's worth noting that if by week 2 they don't start feeling better, we definitely need intervention, because 80% of concussions get better on their own, which is great. So within that 3-week time frame, most people bounce back. Again, just that mild MTBI category. The problem is that if the brain cannot self-correct, it does not get better. It needs help. It needs therapies. We'll talk about what that looks like so that you guys have an idea. But time frame wise, this is kind of what we're looking at in terms of transport, referral, reaction, what warrants immediate, what can wait a little bit. Most common one by far are headaches. 75% of concussion patients will experience headaches. So that's a large amount. So that's part of why headaches are kind of almost always associated or immediately associated with concussion. But I've mentioned this before, they're not a requirement. There are concussion patients that do not struggle with headaches and they fall into different profiles. We'll talk about what those profiles are. Difficulty concentrating is the second most common, followed by fatigue, drowsiness, kind of similar, dizziness, that kind of balance impact, foggy brain fog. My primary always talks about cotton candy brain feeling. That's kind of how we explain foggy to kids. Feeling slowed down, light sensitivity, very common. Sound sensitivity did not make the list, but also kind of, I would wager, similar in terms of statistic. And then memory and balance. I mentioned earlier that there are pre-existing risk factors that people can have to obtaining a concussion. Just because you have those risk factors does not mean you're doomed, but it's always good to kind of keep that in mind. If you're interested more and want to learn more about pre-existing risk factors, I listed a bunch of sources for each one, if you feel like reading up for that. But for the purpose of this kind of talk, we're just gonna talk about what they are and make sure that we're aware of them. Younger age. So when they're little, partially depending on how little, but is their skull fully formed? Is it hard? Is it developed? What kind of height, right? Like if I fall 6 stairs down, that's gonna be a different force for me than if we have a little 4-year-old, right? Different, that height to them proportionally is much more devastating than it would be me. Migraine history and symptoms. People that are migrainers are are much more likely to have headaches during their recovery and are likely to have a temporary increase in migraines. Now, depending on the situation where you encounter the individual, you might not know that about them. But if they're conversational, if they're talking, might not be a bad thing to ask, like, hey, do you get migraines? Or because then if they do, we want to be mindful of that. Learning disabilities, again, probably not topic of conversation for any kind of like MBA, motorcycle crash, but any kind of games, athletic training, those kind of things, that'd be helpful. Female gender. I'm sorry, ladies, I don't have a good explanation for why. Besides Mother Nature is cruel. But we know that females tend to be more prone to concussion compared to males. Some in the literature argue it has to do with neck strength. Again, I don't have a good answer, but that is also a risk factor. Pre-existing motion sickness. People that get car sick tend to get concussions more easily, same as people that have ocular dysfunction. Also, a good kind of little catchphrase is that concussions don't create, they exacerbate. So whatever risk factor we have, we're gonna feel it while we go through our recovery. So for example, I'll give you a personal example. I get car sick. I am not a roller coaster person. I wish I was. I can't do it. So when I have a concussion, I almost always struggle with increased dizziness compared to people that do not have that pre-existing risk factor. Doesn't mean they can't get dizzy from a concussion, but they're much less likely to struggle with that compared to me. Another interesting factor is that if people have on-field dizziness or subacute fogginess, so if they get hit, and again, on-field dizziness, it translates to being at the scene of a car accident just the same. But if they had a hit and immediately dizzy while, like right after, that's typically a pretty good sign that they need to be evaluated, and this is going to be a concussion. Again, it's not a one-to-one correlation, but it does increase the likelihood. So you've heard me mention it, but concussion profiles. Essentially, now I'm going to talk a little bit more on how to conceptualize concussions a little bit better, because I think understanding this injury on a deeper level will also help make good judgment calls on how to care for people better. Concussions are characterized by diverse symptoms and impairments in functioning resulting in different clinical profiles and recovery trajectories. So what this means is that out of these 21 symptoms that I mentioned earlier, research has shown that they kind of cluster in certain groups together. And those groups are now called profiles. The picture you're looking at right now is the old graphic. And so for comparison, before we had 6 circles, now we have 5 and 2 modifiers. So the big difference through research that we learned is that cervical, so neck, is technically not a profile, not a type of concussion. It is a modifier. Basically, the argument is it's not part of the brain, so it should not be a type of concussion. But as mentioned before, anytime there's neck involvement, it needs to be considered, it needs to be addressed. So it's considered a modifier because it can certainly make symptoms worse, right? If my neck's achy, sore, painful, injured, it can radiate up, it can mess with headaches. Also, the vestibular and ocular system get a lot of information from our neck, so very important. We talked about sleep earlier. If the brain does not get enough sleep, cognition is going to be a lot harder, reaction time, motor coordination, all these kind of things. So that's why sleep and cervical are kind of considered these main modifiers. The vestibular system, as you are all well aware, is the part of the brain that's responsible for movement, motion, integration. Where am I in space? I joke with the kids that it's kind of like your internal GPS. And a lot of times when we have a significant blow or a hit that causes this type of injury, the vestibular system essentially gets nudged off the rails, which then leads to this dizzy sensation, off balance kind of feeling. Ocular is obviously the eyes. Really interesting to know is that when we talk about like vision changes or ocular deficiencies post-concussion, it is not about the eyeball itself, right? This is not an injury to the actual anatomy of the eye. This deficit comes from the brain because each eye is connected to the brain, crosses over, you all know the anatomy. With that basically neuronal interference, our brain can't coordinate our eyes the way it normally would, leading to those vision changes, to those impairments. And our brain works really hard to self-correct, like it wants to get better, it wants to get back to normal. But if that hasn't happened by week 2 or 3, it likely is not going to self-correct, and it does require treatment to get back to normal. If left untreated, it can cause long-term problems. Especially, we see this a lot with school kids. They go from being straight A students to all of a sudden failing math because their eyes just don't cooperate. But when they go to the optometrist, your eye is fine because we just check the actual eye, not the brain-eye interaction and the coordination together. There are a lot of optometrists out there that do a fantastic job at catching that, but it often, especially when the deficiency is subtle or more complex, it can get missed. I've seen several patients like that. Cognitive profile, any kind of thinking, obviously decision-making, integration, that requires a lot of energy, very hard for the brain when it's injured. Especially multitasking is incredibly difficult with this kind of injury. And so this, kids at school, people at work, depending on what their job is, so that can make things difficult. Post-traumatic headache, we talked about it. Headache is the most 75%, the most common symptom. I wish whoever coined it wouldn't have called it post-traumatic migraine, because migraine, and people always think of something else, but medically it just means bad headache. So that's what we'll call it, bad headache. And then anxiety, mood. We talked about it as a profile. Emotions happen in the brain. So of course that can be impacted when the brain cannot operate temporarily how it normally would. So those emotional changes, whether it is feeling more emotional, whether it is, it can go both ways. Some people feel super anxious and very sad. Other people feel numb. It just kind of goes flat because the brain doesn't have any kind of energy to actually process the emotional sequelae or the emotional activity. So conceptually, if you hear concussion, think of like 5 categories. That being said, those 5 profiles can overlap, meaning if somebody has a concussion, they can have one profile, they can have all profiles, they can have any combination of profiles. So clinically, it's really helpful to know what kind of profile or plural profiles they fall into, because that can really inform treatment decisions. Typically, we think of it as like primary, secondary, tertiary profiles. If they have all, okay, but generally, one or two are typically more pronounced or worse than the others, and that's kind of what will dictate how we go about it. Our body is a system, they all work together, so they certainly sometimes accidentally keep each other in play. So in terms of frequency of concussion profiles, as you can see, headache is the most common one. We talked about it, makes sense. Followed by anxiety, right? I just talked about how common the emotional sequelae is. So that is the second most common profile. So it's very, I think it's very important to acknowledge and kind of keep that in the back of our mind, because I've worked with this injury across all levels. I worked for an NFL pro team for 2 years. I've worked with anything from weekend warriors to pro level athletes to any kind of vocations, policemen, firefighters, pilots, you name it. And the emotional piece can be devastating, especially if it goes undetected or ignored. And so that's really, really important. If you have someone that, you know, all of a sudden is very much not like themselves, don't ever be afraid to ask and have that conversation, because it could be really helpful. I mean, I've had, you know, pro NFL, I had like a 6'6" guy there sobbing, telling me he doesn't understand why he feels this way and what's wrong with him, because nobody had done that education piece yet of how effectful that profile, that piece of this injury can be. Because like I said, a lot of times when we hear concussion, we think headache, but there's much, much, much more to it than that. So note that 10 to 20% of individuals continue to experience symptom beyond that typical time frame that we talked about. And the reason why I harp on that is because we know from research that earlier initiation of clinical care is associated with a faster recovery. So that's why I'm always like, if by the second week you're not starting to feel better, start treatment, seek care. Because the longer you wait, the more we not only have to rehab the deficits from the injury, but we also have to undo whatever coping mechanism the brain tried to come up with to make it work to get through the injury. So it's a lot more work. Recent research focuses on the role of an active approach to rehabilitation and treatment. Physical activity is actually really beneficial during the acute and chronic phase of concussion. Old school treatment approach was kind of like, oh, just wait it out, go lay in a dark room, don't do anything. Not helpful. Out of our 5 profiles, only 1 benefits from rest, and even there, it's intermittent. So rest is not always best. Keep in mind, we are talking about that MTBI category only, okay? Moderate, severe, whole different ballgame. The strongest predictor of a prolonged recovery, so whether someone's going to need longer than that average time frame we talked about, numbers of days to first clinic visit. The longer they wait, the longer they're going to need to get out of it. Okay. Positive findings on the VOMs are also indicative of a prolonged or protracted recovery. We'll talk about the VOMs a little bit more in a second. I talked about this earlier. Anybody that has a history of headaches or migraines tends to take a little longer. Migraines tend to increase during the recovery. And PCSS, which is the post-concussive symptom scale score, the higher the score, the more likely at intake or at, you know, first point of assessment, the higher the likelihood of it being a protracted or prolonged recovery. So you've assessed them, you've evaluated them, you either got them to the ED or you told them like, hey, you should check with your primary, or please go see your concussion clinic. So what happens, right? Essentially, a multidisciplinary approach to this injury is what has proven the most effective. So I'm in the middle of the circle. That's me. I get a lot of referral sources from our ED, emergency department, from my ortho colleagues, from the Sanford Castle, which is pediatrics for where we are at. A lot of athletic trainers, obviously, as well as my primary care physicians. That being said, there is more referral sources. These are just like the bigger ones. PM&R, we send people back and forth. Vestibular therapy, neuroradiology, neurosurgery, depending on what we're working with, behavioral optometry or ophthalmology, as well as behavioral health. And the thing that's kind of missing, which I just added, is speech therapy and exertion therapy. Exertion therapy is very new, but just like we talked about, physical activity is very good for this injury. So exertion therapy is kind of at the forefront of the recent research to find ways to do that in a targeted approach. If you're familiar with sports, you might have heard of something as the Buffalo treadmill test or the exit test. So these are physical exertion exams to make sure that the vestibular system, the ocular system, and our body as a whole is functioning as need be. So we're working on standardizing those. There's a general one, but we're also working on finding or creating sport-specific portions, because obviously a gymnast has very different demands than, let's say, a linebacker. So clinical evaluation, I mentioned this earlier. On the right side, you'll see the VOMs. I'll talk about that. But essentially, if you send someone to my clinic, or if you ever find yourself in a situation where you need to come see us, this is kind of what it would look like. At first, we do a detailed clinical interview where we ask a bunch of questions. I review the medical records, make sure I have a good understanding of how the injury occurred. Then I complete what's called the vestibular ocular screening, or also short the VOMS. I mentioned this earlier. Essentially, it's a cranial nerve screen, but it's really, really effective. It's out of the Pittsburgh group at UPMC. It is very, very good at identifying concussions and kind of helping with those predictors in terms of dizziness. So it checks for ocular and vestibular dysfunction. Then patients usually complete a computerized neurocognitive test. The most common one is the impact. There are other versions available. One is called C3 Logics, and now Sway is also rivaling the market. The battery is pretty standard. I will make adjustments based on what people present with. Like, for example, if I have a child that has significant learning disability, we might need to accommodate. And then also for my multiple trauma people, if they have multiple broken bones or whatever, we might have to adjust because they might not be able to use their hands or whatever. The exertion evaluation is not available in all places, but it is incredibly helpful if it is available, because it gives a deeper understanding not only of the cardio state, but also the dynamic movement and tolerance. So all that information is basically put together to establish a diagnosis, and then also help with prognosis, as well as establishing the profile situation and a subsequent treatment plan. Now, as well as a return to play or work, depending on what person we have, right? Athlete, school, sports versus adult, job, maybe recreational activities, depending on what they like and what they're into. In terms of most common referrals, about 28% of people of this study portion require physical therapy. And when I say physical therapy, 90% of that is vestibular physical therapy. So retraining that balance, that vestibular system. Obviously, a lot of them also do neck kind of PT to help with that, but this specifically refers to vestibular physical therapy. Speech therapy, A lot of people benefit from that, especially in that cognitive profile. So it's a little bit of a misnomer, his speech, but it actually does a lot for the cognitive rehab. Occupational therapy. So this will heavily depend on where you're located, because state legislation can significantly impact this. So for example, Pennsylvania, where I trained, the vision therapy was completed under the physical therapy umbrella, versus now here in South Dakota, where I'm currently located, a lot of my vision therapy, and I say this because it's not through optometry, but it is vision rehab, is through occupational therapy. So where you are will impact how to obtain certain services. The nice thing about this is that all of these are typically covered by insurance, which is also why I always go through occupational therapy for vision deficits first, because a lot of times, or almost all the time, vision is not covered under insurance unless they have specific vision insurance, kind of like, I don't know who decided that ICE should be part of that, but anyway. 46, so almost half of the patients are referred to one or more discipline. Remember, you can have more than one profile. So it's always good to kind of have an idea of what we're dealing with to make sure that the referrals can occur appropriately. It did not really matter what the mechanism of the injury was. So like, meaning individuals that get injured during sports or car accident, they all kind of end up in similar need of these rehab services. And that's also why I said earlier, I don't really distinguish whether it's a sports concussion or a work injury, slip and fall, car accident. I mean, it matters in terms of like what we need to do to get the individual back to their normal, but it does not make a difference from a referral or treatment point, how it occurred. As mentioned earlier, good resources. So the International Concussion Consensus Conference just happened. Well, not just, it's longer than I thought, but we went in October last year. Time flies. So as you can see, that's me and my team. We got to present our research, and they have released the new consensus statement. I would encourage you to take a glance. It has very, very good information. Yes, this is focused on sports concussions, but again, conceptually, not that big a difference. So it can be really helpful and has useful information. So in conclusion, what I want you to take away from this: concussions are heterogeneous injuries. It's not a one fits all. They're not all the same. And the more we can have that awareness, the better we can serve our patients. Prolonged symptoms can be attributed to pre-injury risk factors, post-injury factors, as well as quality of clinical management. Remember, the longer it takes for them to get assessed, the worse it can, or the longer it's going to take them to get better. Early detection improves outcome. So especially when you have someone, like, let's say you get to the scene of a car accident and they're kind of like hyped on adrenaline. They're like, no, I'm fine, I'm fine, I'm fine. Plant the seed. Tell them like, hey, I'm glad you're fine right now, but if you start having headaches in the next day or two, or feel woozy, or go get checked. Okay. If you do know of people having a complicated history or several risk factors, might be worth referring anyway. And like I said, if there's no improvement after 2 weeks, they need to get checked. Treatment should focus on identification of the profiles as well as targeted treatment, because again, it's not a one fits all. As with everything in medicine, there's always more research warranted. We're still learning, but things have tremendously changed, especially in the last decade. Remember, rest isn't always best. So takeaway, kind of these are the, like, if you don't remember anything else I just talked about for an hour, try to remember these things. If they have red flags, they need to go. They need to get checked. If you've seen one concussion, you've seen one concussion. They're not all alike. Symptoms don't always show up immediately. There is a delay. So just because someone looks good right after doesn't mean they're out of the woods just yet. Loss of consciousness or findings on imaging, CT, MRI, are not required for a concussion diagnosis. Your imaging can be completely fine and you still have a concussion, because remember, metabolic injury, functional, not structural. concussions do get better, not worse. So if that doesn't happen, something's off, something was missed. We do not anticipate long-term problems from MTBI. They are treatable, they're not the boogeyman if done correctly. The only thing that will worsen a concussion is additional trauma, is another blow. That will make things worse. Normal recovery can be anywhere from weeks to months. It varies on what we're dealing with. Again, 2 weeks to 6 months is considered normal. But even beyond that, doesn't mean that they can't get better, doesn't mean there aren't things to get them back on track. Complete rest isn't best. We don't want people to do nothing, to just be couch potatoes. The first 24 to 48 hours, you can sleep as much as you want. After that, I need you to get moving. I need you to have some kind of a routine, even if you just go check the mail, come back, kind of establish a normal schedule. When in doubt, consult, find somebody, find me, reach out, have a discussion. Research shows that EMS is equally good at identifying concussions as MDs. So you know what you're looking at, you know what you're seeing, work with it, help your patients. Anybody have any questions? I know I threw a lot at you. Nope. Okay. Any kind of reference, like all the references that I used, if you have any other concerns, questions, feel free to reach out. I'm happy to help if you're ever not sure about referrals. I'm happy to chat. And yeah, if you have anything else, or if you want me to talk about something more specific, just let me know. Otherwise, thanks for having me.
Thank you for joining us tonight. Have a great night, everyone.